1997. This is an excerpt from my 6th grade yearbook. I wanted to become a cardiologist and I'm interested in heart pacing. I left when I finished high school, and 20 years later, which is 10 years ago this year, I came back into practice here in El Paso and then joined UMC last summer full-time. So the objectives of my talk are to understand initial evaluation management for patients presenting with atrial fibrillation, discuss recent clinical trial data regarding catheter ablation, and then review the data regarding surveillance for asymptomatic atrial fibrillation. Now, the title of my talk kind of changed between one version of the program and the other, so the title that Dr. Mukherjee mentioned is just the end part, but that part is all new stuff that I made just for this occasion. So we're going to start talking about what is atrial fibrillation, treatment, catheter ablation, and the title was originally, Controversies in the Management of Atrial Fibrillation. So the first one will be the Command trial results, and then we'll talk about stroke prevention and prevention of atrial fibrillation. I wasn't sure about everyone's level of knowledge about AFib, so I kind of went a little bit back to basics. And if I don't want to offend anyone by having done so, but normal sinus rhythm starts in the upper part of the right atrium, propagates through the atria to the AV node, and then it goes. Okay. Atrial fibrillation is where there's chaos. The atrium is fibrillating. The AV node conducts that in a rapid and irregular fashion. And it can result in a spectrum of symptoms ranging from syncope all the way to people who have no symptoms at all. The prevalence of atrial fibrillation is inferred from large insurance databases, 2.3 million estimated in 2001, 5.2 million in 2010, projected to be 12.1 million by 2030. In 2001, the estimated cost for the treatment of atrial fibrillation was about $6.5 billion. For comparison, treating coronary disease in the United States cost $444 billion. So as I mentioned before, our treatment is divided between rate control and rhythm control. The decision to get a patient out of atrial fibrillation is guided by the symptoms, and this is really shored up by a hallmark study that was published in 2002, the AFFIRM study, over 4,000 patients at age over 65 randomized between rate control and rhythm control with a 3.5-year follow-up. And there was no significant difference in mortality or stroke rate, which has led to our current paradigm of going into rhythm control for atrial fibrillation primarily based on symptoms because of a lack of benefit for hard endpoints, mortality or stroke prevention. And you have to think that a study that was published in 2002, it takes at least a year to get the paper published, and it takes at least 2 or 3 years to collect the patients and collect the data. So we're talking about practice that was 20 years old. And if you think about what we're doing now versus 20 years ago, there's a lot of things that are different. And it's just, I'm not saying that AFFIRM is not valid, but it's something that we have to keep in mind when we talk about hallmark paradigm shaping trials, that they may need to be updated. Next, we're going to talk about the definitions of atrial fibrillation. We define paroxysmal as episodes that last less than 7 days. Persistent is longer than 7 days, but less than a year. And chronic means no further attempts at restoration of sinus rhythm. The latest updated guidelines, which were updated last year for rhythm control in patients with paroxysmal and persistent atrial fibrillation. In the absence of structural heart disease, recommend the use of these antiarrhythmic drugs, dofetilide, dronedarone, flecainide, baclofen. And in both arms, amiodarone is a second-line antiarrhythmic drug after failure of these other drugs. You cannot use the class 1 antiarrhythmic drugs, so flecainide and propafenone in patients with structural heart disease, so that's the big difference here. And then the big other new thing is that there's this dashed line, including catheter ablation, possibly as a first-line therapy. I summarized the pages of indications into this slide. So catheter ablation for atrial fibrillation, now a class 1 indication in paroxysmal patients, meaning episodes last less than 7 days that are refractory to a drug. It's a 2A, meaning you should think about it. In paroxysmal patients before trying a drug, or persistent patients who recurred despite antiarrhythmic drug therapy. And 2B in the persistent before trying a drug, long-standing persistent, and in the setting of a low ejection fraction. We'll get to the clinical trial that led to this being inserted. And then discontinue of anticoagulation, meaning trying to get rid of atrial fibrillation completely, is a contraindication to doing a catheter ablation for atrial fibrillation. And if you have a patient who comes and is found to be in atrial fibrillation, and we're not sure how long it's been going on, I think it's worth considering a trial of sinus rhythm to see if they have any symptoms. I've had multiple patients who say they feel just fine, and when we get them back into sinus, they've been compensating for their exertional symptoms and felt better in sinus rhythm. And I think that's an important thing to consider doing. So what is catheter ablation? This is a picture of an ablation catheter. This particular one is irrigated, meaning it pumps saline out the tip. And the way this works is the catheter is positioned to record something you want to destroy. In this case, I depicted that by a star. Radiofrequency current is turned on, and the current goes between the catheter tip and a contact pad on the skin, the grounding pad. You get resistive heating of the catheter tip and conduction and radiation of the heat to the tissue. And then you get coagulative necrosis once the tissue temperature reaches 50 degrees for more than 10 seconds. This is a picture from an animal lab I went to a few years ago where we placed ablation lesions in a porcine right atrium. You can see lesions, lots of different people placed lesions. You can see kind of what the lesions look like acutely. So what is an ablation for atrial fibrillation? This story goes back to the mid-1990s. There was a French electrophysiologist named Michel Hasseguer who made the observation in patients who didn't have any other heart disease that the triggers for atrial fibrillation seemed to come from the pulmonary veins, the veins that drain the lungs back into the heart. And this is actually a recording from one of my cases. This is an intracardiac recording, so it's 200 millimeters per second sweep speed, so it's 8 times wider than your clinical EKG. Just as a point of orientation, the top is the surface electrocardiogram. There's a right atrial catheter. There's a catheter recording a His bundle, which is kind of in the center of the heart, recording the right ventricle. There's a circular catheter in the left superior pulmonary vein. We have an ablation catheter and then a catheter in the coronary sinus, which is the vein that goes behind the left atrium and lets us see kind of what the left atrium is doing. And what you'll see here is this patient is ventricular pacing with retrograde conduction, so ventricular pacing conducting to the atrium. And then you get PACs firing, 3 from the pulmonary vein. This is the first atrial signal. And then after the third one, it becomes a chaotic rhythm. You can see the signals have no order to them. So this is the pulmonary vein firing, triggering atrial fibrillation. So what we do is called pulmonary vein antral isolation. So we place ablation lesions around the pulmonary veins to block electrical conduction between the vein and the rest of the atrium. The way we do this is to get into the left atrium by a transeptal puncture going from the groin. The patient's usually under general anesthesia. The procedure takes about 4 or 5 hours, and we have an overnight hospital following. This is going to be a movie showing you kind of how this works. So this is something called a pentaray. It's a mapping catheter. It's like a balloon. It has 5 fronds on it. Each frond has 4 electrodes. And we use an electroanatomic mapping system that can see the pentaray, and as it's moving around, it builds a shell at the inside of the left atrium. At the same time, the computer collects data from the signals recorded from each of the 5 splines, each spline having a pair of electrodes, and assigns color based on the amplitude of the signal. You can see this is the raw data that it's collecting. The yellow dots are when it thinks that it's obtained a data point, and it's acquiring these in relatively rapid fashion. The purple means that the tissue is relatively healthy, and then this is the map we get when we're done. You can see we have 4 pulmonary veins. There's the left atrial appendage, and this particular atrium is relatively healthy. Once we've made the initial map, and again, this is all done without fluoroscopy. Once we've gone transeptal, we turn the X-ray off. Then we start ablating. And our ablation catheters now report the force with which we're contacting the tissue. And as we ablate, as the power comes on, the system automatically creates a point suggesting that we've done an ablation only if we've been stable, staying in the same position with an adequate force for a pre-specified period of time. So essentially what we're doing is an anatomical ablation to circumscribe the pulmonary veins. And we want to see, as we ablate, the signals in the ablation catheter shrink, which we did there. The catheter just moved, and we're ablating the signals shrink. And eventually we'll see these signals in the pulmonary vein go away. And at the end, this is the picture of the map before. When we're done, after we've done all this ablation around the pulmonary veins, you can see the electrical signals now have become red, which means there's nothing detectable, and we've successfully isolated the pulmonary veins. The success rate for reducing the recurrence of atrial fibrillation is quoted around 80%, and this is actually very early collection of a series of uncontrolled studies that reported this, and this is still true to this day. About 80% freedom from atrial fibrillation off drug in paroxysmal patients. I said I was going to talk about the data that led to the insertion about heart failure being a 2B for catheter ablation. That's this Castle AF study. It included paroxysmal and persistent AFib patients with an ejection fraction less than 35%, 363 patients randomized to ablation versus rate control. Not blinded, obviously, because you don't do sham procedures in this particular case. The primary endpoint was death or heart failure hospitalization with a median follow-up of about 3 years. And using that composite endpoint of death or heart failure hospitalization, there was a statistically significant 38% reduction in the endpoint over that median follow-up time. Interestingly, death and heart failure hospitalization each individually had a significant benefit with catheter ablation. And the EF increased on average 8 in the ablation group with no change in the conventional rate control group. There's been a lot of criticism of this study because it was not blinded, and we still have a question about the version of rate control that doesn't involve pharmacologic therapy, and that would be ablation of just the AV node, leaving the atrium fibrillating, and placement of a pacemaker, and then the heart rate is controlled by the pacemaker. We don't have data comparing catheter ablation to restore sinus rhythm versus rate control with that ablate and pace strategy. So as I mentioned, AFib was published in 2002. The clinical practice at the time was 20 years old. So an attempt was made to update AFib using catheter ablation. And the name of the study was called the Cabana trial. Compare catheter ablation with state-of-the-art drug therapy. And I'll tell you, Cabana was talked about for 10 years before it came out. And every year for the last 5 years, everyone kept asking, when is Cabana coming? When is Cabana coming? So AFib was a mortality study. It had a simple primary endpoint, and that was mortality. They weren't able to do that because the mortality was felt to be low. They had to come up with a primary endpoint that was a composite of mortality, stroke, bleeding, or cardiac arrest. But they left mortality as a secondary endpoint, followed as well as a combination of death or cardiovascular hospitalization. And I'll say this endpoint was used for the approval of drug therapy in cardiovascular disease. Specifically, this was the endpoint that was used that supported the approval of dronedarone, Multac, for the treatment of atrial fibrillation. So Cabana included 2,200 patients randomized to ablation versus drug therapy. There was a significant amount of crossover between both groups, but they had pretty good completion of the study protocol, about 42% paroxysmal, 47% persistent, with an average of 1 year since the AFib was diagnosed. And this is the first results study, first results slide. Using that composite primary endpoint, death, stroke, bleeding, or cardiac arrest, there was no significant difference between antiarrhythmic drug versus catheter ablation therapy with a p-value of 0.3. Looking at the secondary endpoint of this mortality, also no statistically significant difference. And this is using an intention to treat analysis. So that means if you were randomized to one group or the other, regardless of what happened, you were included in that group for the analysis. So these results were first revealed at the Heart Rhythm Society meeting in 2018, in May of 2018. And when they came out, a lot of hand-wringing began. There was even an editorial written in the New York Times by a cardiology fellow at Duke, "Don't put that in my heart until it works." And he had written, Cabana trial showed the procedure was no more effective than cheaper medications. Anyway, this particular fellow was derided widely for his audience being so broad in the New York Times. But if you look further, you'll see that the results are not so bleak. Interestingly, the Cabana trial was not published until over a year later. And that tells you that, because most big trials, when they reveal the results at a big meeting, the publication is at the same time. So there were some problems with how the investigators and the EP community wanted to put out this data. And it still remains a little bit controversial. So if you look at the intention to treat of the combination endpoint of mortality and cardiovascular hospitalization, which again is a valid endpoint that the FDA takes for approving a drug to treat cardiovascular disease, there was a statistically significant difference, 17% reduction between antiarrhythmic drug and catheter ablation if you use this endpoint. And it's a pre-specified secondary endpoint, so I think it's a valid endpoint. But then the investigators went a little bit further. They said, we had so much, if you look at the result as far as eradicating atrial fibrillation, that's what this Kaplan-Meier curve shows, the first recurrence of atrial fibrillation, again using the intention to treat analysis, we reduced that by 47%, which is statistically significant. And again, there are late recurrences of atrial fibrillation, but if you look at the endpoint of are we getting rid of AFib, we are doing it more with ablation than drug, and so that's good. The investigators then went on to say, well, we had so much crossover, so why don't we do a treatment received analysis? We say everyone who got an ablation goes in one group, and everyone who didn't get an ablation goes in the other group, and we'll compare those. And when you do that, the primary outcome as well as the secondary outcomes all are statistically significant. But that's unfair to do because it violates the randomization, right? The decision about who crosses over or not is made by physician preference. So then they went on to do what's called a per protocol analysis. And what that means is you get randomized to ablation, you get randomized to drug. And if you cross over, you're counted as a failure to follow up. So per protocol means only the patients who completed the protocol they were randomized to are included in the analysis. And if you do a per protocol analysis, the primary endpoint has a 27% reduction in this huge composite endpoint, and a p-value that barely registers significance. And that's why I think this remains controversial. I was on vacation when the Heart Rhythm Society meeting happened where they revealed the results. I was visiting Petra in Jordan. And the initial reaction was disappointment. There's no mortality benefit for AFib ablation. The primary endpoint was negative in the intention to treat analysis. Are we EPs all committing fraud? But here's my take. I don't want to have to do AFib ablations in everyone, in every 95-year-old who's missing a leg who comes with AFib. Cabana validates our current practice, which is to do ablation primarily in patients with symptoms. And then if you take a patient who has AFib and you put them on an antiarrhythmic drug, you're not harming them in comparison to doing ablation. And certainly, I think what's happened in the aftermath of this is it gives us gives the EP community a little bit of leeway to sort of say, well, I think it'll work in you, so Cabana says that you'll do better if I do it, if I use the per protocol analysis. Based on the comorbidities, I think you're not going to do so well with catheter ablation. You'll be just fine if I give you antiarrhythmic drugs. So this is a controversy, and I think it actually came out okay. And I don't think we're going to get another big trial because it took so long to get these results. It's very hard to enroll patients into a randomized trial where they already know they have a problem, and one arm is to try a drug and the other is to have a procedure. There was a lot of discussion about trying to do sham ablations, to do another Cabana trial where everyone got on the table and had sheaths put in their leg, but I think that's been put down as being unethical. When I've gone back and looked at my results from a small series, 52 patients for catheter ablation with atrial fibrillation, 20 of those were persistent, 7 had a prior ablation, and this is just clinical follow-up when they come see me, how they're feeling and whether they're in sinus rhythm when I listen. 42 of those patients completed the follow-up, 90% were in sinus rhythm at 12 months. The majority were still on antiarrhythmic drugs, and the reason for that is a lot of them are on Sotalol, which is a beta blocker. You may have an indication for a beta blocker. And when we have the discussion, you're doing fine, you want to switch medications, not stop one, but switch from one to the other, and you may have AFib again. They say, well, just leave me the way I am. And then about 3 out of this so had repeat ablation for recurrence of atrial fibrillation or atrial tachycardia. Am I going too fast?
You're good.
What? A little bit? No, good? Okay. So this is the juicy part of this, where we actually talk about a stroke and a cardiac condition at the same time. I mean, others have done this, but atrial fibrillation is really kind of the nexus for that. We had the CHADS-2 score, which has now been improved to the CHADS-2 VAS score to risk stratify patients with atrial fibrillation as far as their risk of having an embolic event and whether or not they would benefit from anticoagulation. Each of these risk factors gets a certain number of points, and essentially, as Dr. Obajima showed us, if a patient has more than one risk factor, notwithstanding gender alone, we recommend anticoagulation, either with warfarin or novel oral anticoagulant. If the score